Significant hyperkalemia is a potentially life-threatening problem that requires prompt identification and management. This vodcast will review the key elements of pathology and treatment. 98% of total body potassium is intracellular, while plasma levels are held significantly less. This is largely due to the activity of the sodium-potassium ATPase pump that is present on the membranes of most cells. The concentration gradient generated by these pumps is a major contributor to the membrane potential and is thus significant in certain excitable cell tissue types, such as muscle, heart, and nervous tissue. In health, the kidneys excrete approximately 95% of the total daily potassium intake. Potassium excretion is regulated by the activity of the distal convoluted tubule and collecting duct. Here, potassium is actively secreted into the lumen under the control of two major forces: the rate of flow and the solute concentration of the urine passing through the duct, and the effects of aldosterone. The faster the flow and the lower the concentration of urinary potassium relative to urinary sodium, the more potassium is lost. Aldosterone promotes the active secretion of potassium at the expense of sodium ion retention. Small changes in the extracellular fluid potassium concentration can have profound impacts on membrane potential. Consequently, the extracellular component is tightly regulated by the body between 3.5 and 5 millimoles per litre. Hyperkalemia results in depolarization of cell membranes. This means that it is easier for the cell membrane to reach activation threshold and cause resultant depolarization. In effect, this results in slowed conduction and decreased duration of action potentials. The physiological effects of hyperkalemia are in part determined by the degree of serum potassium concentration elevation. Commonly, hyperkalemia is divided into mild, moderate, and severe groups based on the concentration as shown here. Other factors that modify the impact of hyperkalemia include serum pH, sodium and calcium concentration, and the rate of rise of the serum potassium. For example, patients with chronic renal failure will tolerate levels that would cause critical illness in patients without previous exposure to hyperkalemia. Calcium plays a role as the physiological antagonist to potassium. Simultaneous hypocalcemia can exacerbate the features of hypokalemia and must be corrected. The primary cause of adverse outcomes is the effect of hyperkalemia on cardiac function. A variety of pathological rhythms may develop, including extrasystoles, both ventricular and atrial, pauses, bradycardia, QRS widening, ventricular fibrillation, and asystole. Peaked T waves are the first ECG sign of hyperkalemia to appear. This can occur at potassium concentrations over 6 millimoles per litre. Progressively, the QRS may widen and the ECG may develop a shortened QTC and ST segment depression. Further increases in serum potassium result in PR delay, decreased P wave amplitude, and eventually sinus standstill. The QRS widens further as serum potassium rises until an organised rhythm resembling a sine wave is seen. This is a pre-terminal event. Ventricular fibrillation or asystole will rapidly follow unless immediate action is taken. Weakness, fatigue, paresthesias, and cognitive problems are likely associated with dysfunction of the central nervous and peripheral nervous systems due to alterations in membrane potentials. Reduced deep tendon reflexes, weakness and respiratory insufficiency may eventually result, although these are late signs. The ECG itself is a poor indicator of the actual potassium level. Rarely, the first ECG manifestation of severe hyperkalemia may be ventricular fibrillation. However, ECG changes do indicate the potential for developing life-threatening dysrhythmias. A number of causes for hyperkalemia exist. Sampling of blood may result in hemolysis of erythrocytes, leading to high plasma concentrations in the sample. This can be overcome with good technique. Sampling from an IV arm may also give you a spurious result, often in a pattern reflecting the constitutions of the IV fluids being infused. Thrombosis and leukocytosis are rare causes of a laboratory error. A decrease in potassium elimination may occur in acute or chronic renal failure. Potassium-sparing drugs, urinary obstruction, Addison's disease, and certain types of renal tubular acidosis may also reduce potassium elimination. In pathological conditions that result in cellular lysis, intracellular components such as potassium may be released. Examples may include rhabdomyolysis, tumour lysis, and hemolysis. Reabsorption of hematomas in trauma may also be a contributor. A number of drugs may lead to potassium shifts in and out of cells, including digoxin toxicity, beta blockers, and succinylcholine. A rare cause is familial periodic paralysis, which can present with episodic periods of weakness and hyperkalemia. Dietary intake is a rare cause in its own right, although in patients who are susceptible for other reasons, it may be contributory. Foods such as oranges, tomatoes, and bananas are particularly high in potassium. ECG changes and potassium levels greater than 6 require continuous cardiac monitoring and regular potassium testing. The degree of urgency for management of hyperkalemia cannot be based solely on the ECG changes or the absolute potassium levels. Mitigating factors such as chronicity of changes, serum pH, and concentrations of sodium and calcium should be remembered. The ECG is insensitive, and the first sign of hyperkalemia may be the development of a terminal dysrhythmia. However, given the relative safety of the therapies available for hyperkalemia, immediate management is indicated if ECG signs are present, or if the serum potassium is higher than 6.5. The role of calcium therapy is to stabilise the myocardium and to prevent the development of life-threatening arrhythmias. Calcium therapy does not lower the serum concentration of potassium in its own right. Calcium is given at the dose of 10 mL of 10% calcium gluconate and is expected to have an onset of action within 5 minutes and last 30 to 60 minutes. It is indicated in any patient who has significant ECG changes, such as QRS widening, P-wave changes, sinus arrest, or dysrhythmias. The endpoint of therapy is correction of these changes, and repeated dosing may be required, usually if changes are not seen within 5 minutes. Calcium is not indicated if the sole ECG change is peaked T-waves. Avoid calcium if the cause is related to digoxin toxicity. This is because intracellular calcium is raised due to the actions of digoxin in toxicity, resulting in electrical disturbances seen in this type of overdose. Administering calcium in this setting may result in intractable dysrhythmias. In this circumstance, magnesium should be used. Calcium itself has no effect on serum potassium, and other methods, as will follow, will be required. The effect of calcium is seen regardless of whether the serum calcium is low or normal. Administration of bicarbonate has been assumed to have an effect on serum pH that results in a transient intracellular shift of potassium. In reality, the evidence supporting its use is poor, and some studies have shown very little impact on serum potassium acutely. It is thought that an effect will usually be seen only when the patient is acidemic, though this too remains controversial. Bicarbonate's role may actually lie more in prompting long-term renal loss of potassium, rather than the acute effect of lowering serum concentrations. Bicarbonate may also exert some effect by modulation of the serum sodium level. This mitigates the change in resting membrane potential. Bicarbonate remains an established therapy in hyperkalaemia, and the dose is 1 milliequivalent per kilo, given as 8.4% for adults and children and 4.2% for infants. Repeated doses may be indicated if a response is not seen within a few minutes. The effect of bicarbonate is seen for around 20 to 30 minutes. As sodium bicarbonate is a strong osmotic agent, rapid volume expansion may occur, and careful observation for this complication is required. Insulin and dextrose greatly increase the cellular uptake of potassium via the sodium-potassium ATPase pump. An intravenous dose of 10 units of rapidly acting insulin, along with 25 grams of 50% dextrose, is usually given. An effect is usually seen within 15 to 30 minutes, usually lowering serum potassium by 0.5 to 0.8 millimoles per litre, and the effect may last for upwards of an hour. Frequent blood sugar estimations should be made, and a dextrose infusion is commonly required. It has long been recognised that beta-adrenergic agents stimulate cellular uptake of potassium, an effect that is additive to that of bicarbonate and insulin. 10 milligrams of nebulized salbutamol may reduce the serum potassium concentration by up to 0.5 millimoles per litre, lasting for several hours. The dose can be repeated with additional effect. Up to 40% of patients do not respond to beta agonists. Background beta blockade may contribute to this, but it has also been seen in other patients, and the reasons for this are unclear. For this reason, this therapy should not be relied upon as the sole management strategy. Salbutamol may be infused too. For example, 500 micrograms can be given over 15 minutes via IV infusion. This can result in a more profound reduction of up to 1 to 1.5 millimoles per litre. Forced diuresis, particularly with loop or thiazide diuretics, can enhance potassium wastage. In practice, this is often not feasible due to the pathological process causing the hyperkalemia in the first place, and because of the delay and variability in action. As mentioned previously, bicarbonate may have a role in facilitating renal loss of potassium. Resins that bind potassium can be administered to the GI tract, enabling enhanced excretion. Sodium polystyrene sulfonate is an example, and is marketed as K-exolate or Resonium. When given orally, it is associated with a reduction in potassium concentration by 0.5 to 2 millimoles per litre, with an onset of 2 hours and a duration of action of up to 12 hours. These resins can also be given as a retention enema for patients in whom the oral route is unavailable. Multiple doses are often needed. Colonic mucosal necrosis may be a significant complication of this therapy, and most patients become constipated. Dialysis is the extracorporeal mode of renal replacement of choice, though potassium can also be rapidly controlled using hemofiltration. Dialysis should be considered early in rhabdomyolysis for a number of reasons. In this circumstance, it is potentially dangerous to give bicarbonate, because serum calcium levels are likely to be very low. Giving bicarbonate worsens this and may potentiate the hyperkalaemia. Similarly, it is likely that administration of calcium will be ineffective due to the rapid complexing with intracellular elements released from the tissue. Hyperkalemia is a life-threatening electrolyte disorder that requires immediate management. Traditional ECG signs are not 100% reliable in predicting serum concentration or the likelihood of malignant dysrhythmias. Initial stabilisation of the myocardium can prevent disastrous dysrhythmias, allowing time for other therapies aimed at reducing serum potassium to be given. Bicarbonate, insulin-dextrose infusions, and adrenergic agonists can buy further time, lowering the potassium concentration for up to a few hours, allowing time until therapies that remove potassium from the body can be implemented. Finally, potassium binding resins and dialysis can be used to lower the total body potassium. If you enjoyed this presentation, why not visit our websites at www.crit-iq.com and www.crit-nurse.com. Critique is a leading provider of online educational resources for critical care clinicians. No matter what your level of experience or training, Critique has something for you. Our regularly updated journal club and podcast interviews will help to keep you up to date with the latest news, while our Echo database and modules teach you new skills. We even have a series of new apps to help you on the go. You can even join our open access blog and have your say on current topics. Critique, critical for life.